This was your ventricular tachycardia. Just go through the medications, in particular the ones in your protocol. In the A&P lecture, I talked about Vaughan Williams classification of drugs, right? This is all the drugs that you're going to learn for all your antiarrhythmics. We're going to get through all of them, not today, but eventually. You got a question?
No.
Stretching? All right. So the class 1, right, is a sodium channel blocker. Class 2 is a beta blocker. Class 3 is potassium blocker. And you have class 4, calcium channel. And then we have additional classes. This here will be like your max sulfate, adenosine, that are not listed here, right? But you definitely need to know these medications. Why I said that you don't want to have a mixed bag of stuff, because if a patient is on the beta blocker, you give them some lidocaine, then you give them some amiodarone, right? You block off too many channels, right? The ones I want to focus here is the lidocaine, class 2B, class 1B, sorry, and then class 3 is amiodarone. These medications here, on this end, they prolong the QT interval. And this prolongs the QT interval. So class 1A, class 1C makes your QT interval longer. Class 1B does not, right? And this prolongs your QT intervals, especially these two medications, sotalol and amiodarone.
I have a question.
Yeah.
Like, instead of blocking off all of these channels, wouldn't it just be safer to correct, like, say, for example, some bicarb, and then, like, for hyperkalemia, calcium, instead of blocking everything?
The thing is, sodium bicarb will not correct that.
Like,
Sodium bicarb, yeah. So the way sodium bicarb works, if you remember the formula, CO2 plus H2O is going to make carbonic acid and dissociate into hydrogen ion and bicarbonate. The way you will basically remove the acidosis, you're going to breathe faster. That will not affect right down the line etiology, right? If you have ischemia and your cells are dumping potassium into your surroundings and they're causing excitability, right? You're giving them sodium bicarb is not going to correct that condition, right? We could give them, a medication like amiodarone, right, which can help us block certain channels, right? Stop the triggering of this rhythm. Okay. So let's talk about this drugs, right? So I drew this in the A&P lecture. I think this is very important for you guys to understand in terms of how these drugs work, right? So can you point it to the side of the screen? I'm gonna kind of do this. So if you understand this phase of it, right, you will be good for your are you able to grab the board?
I can get closer.
No, but can the camera see the side?
Yeah, yeah.
Oh, perfect. Right. So we're gonna say, we just draw it. I'm gonna make it big so you guys. We're gonna say these are your myocardial cells.
Can I zoom?
What's up?
Can I zoom to get closer or no?
No. It will, as long as you could see this in the viewfinder, it will capture.
Ah, all right.
Yeah. So we're gonna say these are your myocardial cells, and then I'm gonna draw before I trip with this cell. So we said cells have different ion channels. Yes. So we're gonna say inside the cell is predominantly what? Potassium. Outside the cell is predominantly
Sodium.
right? So we're going to say these are your leaky channels. They could send sodium ions in through the are not voltage gated. So a little bit of sodium trickles inside, right? And there might be more of these channels on the cell surface. So sodium is a positive cation. As it comes in, do you think it's going to, right? And inside the cell is usually negative minus 90 millivolts. As sodium comes in, right? Do you think it's going to make it positive or negative? More positive, right? So if we start out at the lower level here, and this is our minus 90, as more sodium is going in, it's going to start to raise this up. So maybe this is minus 80, right? And here we have minus 70. This is minus 90. Everybody with me so far?
Yep.
So positive came in. It took from negative 90 to maybe negative 80, and then negative 70. It's making it more positive. Negative 70 is going to be our threshold potential. Threshold. The moment we hit threshold potential, you see this type of spike. So this type, and we're going to say here maybe plus 10. So the moment this occurs, we have different sodium channels. These are called voltage-gated sodium channels, right? And there's a boatload of these channels are found on the cell surface, right? And they have these gates on them. But the moment they are activated, right, all of this sodium starts to come in. So the moment the sodium starts to come in, it's going to take the -70 threshold up to +10. This we call depolarization, right? So our cells have depolarized. Then the next phase of this, right, is going to be this, like, it looks like a plateau phase like that. And what happens during this plateau phase is that we have potassium channels and we have calcium channels. So we have, here we have voltage-gated potassium channels. And we have voltage-gated calcium channels. So the moment it hits +10, these potassium channels open up. So, and we said the cells are rich in potassium. So this potassium that's found in the cells, right, is going to start leaking out. And at the same time, we have calcium channels that are also open. Calcium is predominantly found outside the cells, right? Calcium 2+, right? Good, like this, and calcium is coming in. So if calcium is coming in and potassium is leaving, it's causing this like a plateau phase. You see how even though there's not exchange of ions, there's no massive drop, right, in our electrical difference. Everybody see that? But after a while, these potassium channels work to excrete or efflux, right? Efflux means to get rid of. Efflux more and more potassium, and these calcium channels, they close. So if they close, right, now you no longer have this equivalence. You have more plus leaving, but nothing is coming inside. So then, right, it goes back down, exactly. So goes back down. It goes back to -90 resting status, right? And they gave these phases, right? Different numbers. This here would be phase 0. Phase 0. This would be phase 1. Phase 2. And then phase 3. So at different phase, different things are happening, right? So let me just reiterate everything I said. Your myocardial cell, right? Resting state -90 millivolts. We know that the cells are bags of potassium and a sea of sodium. These are not voltage-gated sodium channels, right? A little bit trickles in. This can go both ways, right? They can have sodium coming in and out, so they can come in and out. And there's a lot of these channels on the cell surface. But the moment there's enough sodium that comes in to take this from -90 millivolts to a threshold potential, the moment it triggers it, it's like all non-response. It's not like just a little bit of channels open. The moment it hits -70, all of these channels, sodium channels, open up, right? And sodium is coming in, and you see this upstroke, rapid upstroke. This is called depolarization. The moment it reaches +10, we have also voltage-gated potassium channels that are open up. And we know cells are bags of potassium, so we have massive efflux. Potassium is leaving the cell, right? It's going on the cell surface, right? Like this. It's leaving. And at the same time, we also have calcium voltage-gated. These are slower acting. And calcium from the outside, from the extracellular space is coming in inside. So you have this plateau phase where even though you have net exchange of cations, it doesn't drop, right? And then, right, as the time goes on, calcium channels close. So now you have more efflux of the positive cations, and you start to drop. This phase here is called repolarization. So you have depolarization plus repolarization, that we call action potential. And if I were to draw my cardiogram, right, on, like superimposed on this, it will look like this. So this will be right. So you see where depolarization occurs. This is your ventricular depolarization, and this is your repolarization. And then you know cells are connected. Myocardial cells are connected by what? Desmosomes, right? And gap junctions. And gap junctions can what? Propagate ions, right? So sodium comes in, and guess what? Right? And next cell fires, right? So depolarization, repolarization, we call this action potential, right? Which ions are responsible? So initially, right, we have leaky sodium channels, then we have voltage-gated sodium channels, and voltage-gated potassium and calcium channels, right? And then the efflux occurs, it goes back to the resting potential. Your cells also have something known as sodium-potassium ATPases, right? They're these cells that use ATP as the energy source. And what do you think is their job? Sodium-potassium ATPase. So they're called sodium.
They pump sodium. That's good,
How many potassium, how many sodium? And where?
I think it's like 2 sodium, or like 3 sodium and 2 potassium.
And where?
3 sodiums comes in and 2 potassiums comes out. No?
Other way.
Other way?
So remember we said the cells were bags of potassium. And then during this occurrence, potassium left. So for me to get it back, potassium has to do what?
It's to go against the gradient.
Potassium, exactly, and that's why we're using ATP. It has to go against the gradient because cells are bags of potassium, and then sodium has to leave. Why do we need this? To restore our resting status. Make sense? So potassium is coming back from the outside against the concentration gradient. That's why we employ ATP to drive this. This is active transport, right? And we need this to restore it, to make cells again bags of potassium and a sea of sodium. So it has to pump K in, get the sodium out.
So that's why when there's the ATP stops working, and then
Yeah. In your lactic acidosis state, yeah?
And then they get stuck in like a refractory.
Yeah. Correct. So, right? So let me, any questions about this?
So the plateau phase, is that to give it the heart like time to fill?
This plateau phase is basically, yeah, you want, it's not per se to fill, it's basically, this is your, from this point to this point is your absolute refractory phase. So no matter what impulse comes in, it can trigger depolarization to occur, right? And over here, if an impulse comes in, there's going to be a problem. We're going to learn about torsades, right? The moment I extend this, QT interval, the more I make it bigger, then you may have a problem. Then I make it bigger, you have a bigger chance of forming what's called an early repolarization. So you have a trigger that may send them to this polymorphic ventricular tachycardia. I'll show you that next week when we do this.
So is it kind of to help control the rate then?
Yeah, exactly. That's why in those settings we may pace them fixed mode pacing to the higher level to maybe not allow them to slow down the heart rate to trigger this inappropriate rhythm. So this is very important to maintain a precise balance, right, for this phase. The moment we alter this phase, or if this QT interval becomes longer, then you have a chance of triggering that polymorphic V-Tach. I will talk about more in depth next week.
So there's a absolute refractory period and then a relative.
Yeah, so absolute refractory would be at this phase here, and this would be the relative refractory where another stimulus can trigger.
So that's when the problem occurs.
Yes. But if you extend this QT interval, right, then you have a bigger time frame where this can occur. But for the purposes right now for this lecture to not go forward, everybody understands this picture and the channels.
Yep.
The channels, right? So, yeah.
I'm having trouble understanding the second picture, so I get everything up to the first picture.
Which picture? This one?
No, yeah, I get the first picture up to the part, up to past repolarization, but the part of active transport, I don't understand.
Right. So look, we just have the movement of ions, right? So at this point, you see how potassium was leaving the cell? And you saw how initially we have sodium that came in. There, right now, we altered the electrochemistry of the cell. we have a lot of sodium inside and a lot of potassium has left. For me to return the cell back to working order so it can work again, I have to do what? I have to get it back to how it was before.
Right.
I got to get all the potassium back in, I got to get the sodium back out.
Okay.
For me to do that, I have to use ATP as energy. Why? Because cell still has a lot of potassium in here. Cell still has a lot of sodium outside. So for me to work this pump, I got to use ATP.
So there's no like leaky channels for like potassium to come back in?
There is, but they're not gonna, there's so many of those ions that you need some pump to work.
Okay.
And this uses about 25% of all ATP in the body. It's so important for us. This stops working, you're gonna die.
So that's not a second cell, right? That's just like the intracellular fluid. The second
This is the second cell. This is the second myocardial site that has this on their cell surface, on the membrane surface.
Okay, yeah, that's
Yeah, they're all embedded in the membrane surface.
all right.
Does that answer your question?
Yes.
Alright. So this was the drawing, right? That's basically everything I explained about phase 0, 1, 2, and 3. Why is this important, right? The reason why this is important is the drugs we just talked about, right? So here are the drugs. Sodium comes in, right? What is the sodium channel blockers? Right? So for the ones you need to know, right? Like, I block sodium channels. Do you think sodium can rush in?
Nope.
Can I have this fast heart rate, so I'm going to now decrease my fast heart rate?
Decrease.
Decrease. Excellent. Now we go to our calcium channel. We're going to learn that when we do SVTs, right? We give diltiazem. I block this calcium coming inside, right? Less calcium coming in, less contraction, right? Calcium is also used for myocardial contraction, right? Actin binds to myosin, causes the contraction. Then we have, when the potassium is leaving to restore that negative status, we have amiodarone and sotalol, right? You notice they're acting on this down phase of repolarization. That's why they prolong the QT interval, right? And then you have the beta blocker medication, right? Metoprolol, right? Class 2 medications. And this is how the EKG correlates to it. So this is your depolarization. Here's your repolarization. At this point here, right? If I make a line, everything here would be relative refractory. This would be absolute refractory period, right? So by giving this drug, we can stop different phases or decrease different phases from occurring. This is the same picture, just a different color, so you can see, right? So knowing your 1 Williams classification scoring, the cell that I drew, right, in terms of the sodium, right, propagating, this is more for your atria and your ventricles. Your SI node and your AV node, the predominant depolarization channel is calcium. Right, that's why when we want to slow down those SVT rates, right, for SI node, AV node, calcium is what we want to block to give them diltiazem. But everything else I talked about is pertinent for everything else. Right, so here you see calcium, right? It's, as I said, right, calcium is also responsible in your myocardial contraction. Remember, in the muscle chapter we learned, calcium comes in, tropomyosin moves out of the way, actin binds to myosin, and you have the power stroke, right, of your cells. This is just basically your equilibrium potential. So what is this, right? This is inside the cell. This is outside the cell. I said cells are bags of what? Right? So intracellular potassium should be more, right? So look, intracellular is 120. Outside is 4.5, right? That's why when you get a patient who they say abnormal labs in the home, nursing home, what happens? They took their blood, they shaked it, cells break, this potassium from the cells, right, goes outside, all of a sudden it's no longer 4.5 outside, it's outside is 40. And they call you emergency, right? So cells are bags of potassium in a sea of sodium, right? So these are why I'm talking about this. These are your equilibrium potential. So look, so you guys understand how this was working, right? So let's go back to sodium, right? See how it says plus 72? So it wants to reach it. It wants to go to plus 72. So you see how the sodium comes in, how it's taking it to positive 10, because it wants to go to its to positive 72. But before it does that, right, other channels start to work. Then we look at potassium, right? Potassium wants to go to negative 88, right? Yeah. See how it goes back down to negative 90? right? So all of these make sense, hopefully to you guys. Right, so action potential, and then you have the contraction of the myocyte right cardiac muscle cell. Absolute refractory period, so no stimulus can trigger, right? And at this point, it's going to be a problem. We talked about intercalated discs and gap junctions. I think you guys were answering that question. These are your medication. If you want to write down in your notes, this is the most important thing to take away. For lidocaine, I block which ones? Fast sodium channels, right? For your amiodarone, I block calcium and potassium channels, right? So, and for your diltiazem, we're going to get to that, you block the calcium channels. So these are all your antiarrhythmics, right? This is how they work. Some of the reasons we employ amiodarone, so this is the amiodarone clinical indications. The ones we are focusing on today is ventricular tachycardia and monomorphic. It's a first-line agent. Notice they say for polymorphic, right? They say if not associated with long QT interval, torsades the plot, right? Then you could give it. If you give it in torsades, you may cause a lot of problems. So we usually don't want to give this medicine in torsades patients. And we also give this pulseless ventricular tachycardia or VF, right, as an antiarrhythmic of choice for ECLS.
Question?
Yeah.
So this is all for the sustained V-Tach.
Mhm.
What about for that run of V-Tach?
Yeah, you can still give. Yeah, you can still give it.
You're still treating
Yeah.
the run, even
Yeah.
though it converts back to
Yeah.
sinus alpha?
Yeah, because it can come back, right? And if I see those
Okay.
periods that coming in and out, and they're monomorphic in nature,
Yeah.
I'm going to give this medicine.
Okay.
Yeah. Some of the effects, right, that we talked about, right? So besides the potassium and calcium, it does other things, right? It inactivates sodium channels. It has some blockage of alpha and beta receptors. So you have profound hypotension with amiodarone, right? Can block the calcium channels. What happens to the electrocardiogram, right? You'll see prolonged refractory periods. You'll have slow conduction of the AV nodes, right? And you will see these things, right? PR interval, QRS interval, and QT interval prolonged. So the amiodarone prolongs all these things. In the setting of torsades, we can kill a person if it does that. It will definitely decrease the heart rate, right? So decrease sinusoidal node activity, prolong the refractory period. This is good if you have a fast rhythm. I have ventricular tachycardia. I want to slow you down, right? But be careful, right? If you slow down too much, you could kill. And then, right, the one thing I want to show you guys before I send you off to your groups. So, very important thing, right? It will cause profound hypotension. This medication, amiodarone. Also, if you don't employ, right, IV line filter, you could cause basically phlebitis. You guys are not taught that in the hospital. They're definitely placed on micron filter to not cause phlebitis. And hypotension is a very common one. The moment you place someone on this medication, put your monitor in the lowest mode you can get blood pressure. So like blood pressure every 2 minutes, 1 minute, because the moment they start dropping, you need to shut off the medicine, right? Remove it, maybe give them IV fluids, right? Making sure they're lying flat. Very important to know that, right? So and the other common, can you grab it so you can see? So this is amiodarone, this is back, this is not a D5W, this is normal saline. I just want to show you what happens if you have the following situation. So you're going to mix it when you do this administration. I'm not wearing gloves, you definitely should. And you definitely should clean all your ports. I'm showing this not for how properly injected. I'm showing you something that is going to happen if you don't do this right. That should be enough. So I pulled this out, right? And what I'm going to do is I'm going to inject this into the bag of saline. You're going to use your D5W. You're going to cleanse the ports. So look, so it's mixed, right? And then you guys tend to do this. Right, because we got to mix it. And you see what's happening? It bubbles, right? And what's the problem with bubbles? Yeah, and if you're using a pump, yeah, it's going to be alarming. So when you put this drugs, don't do this, right? The way you want to mix it is you want to slowly, right, up and down like that, put a label on it, right? Don't agitate it like frequently like this. You're going to see all this air bubbles? And this will, if you're using an IV pump, it's going to alarm. If you're giving it through the line, right, it will do that. So this is, it comes in a vial like this. You're going to be mixing it, 100 ml D5W. This is saline. I'm just showing you as a demonstration, right, not what you're going to be doing. You're going to be using an administration set to connect it. My advice to you, right, as you're preparing, put a label on it so you know what medicine you're giving, right? Use appropriate fluids, all that. Any questions about that? Blood pressure every 2 minutes. So this point is why it's important is right the moment the blood pressure starts dropping, right? What you want to do is the first action. Stop your amio. Stop this. So let's say I got a patient, right, and I start to infuse this medicine. All of a sudden, BP went from 110 over 60. Now I look, it's 80 over 40. I stop this immediately. I never mainline this. Mainline, you know what's mainline? You have IV access and this tubing. This tubing goes like this to your, right? Let's say this spike the bag. Don't ever do this. So we got the amiodarone, right? Let's say we mixed it right, we flushed it, everything's fine, we have IV access. You guys did this. You're infusing it. All of a sudden my BP is dropping from 110 to like 80 over 40 or 70 over 40. I close off this medicine. What's the problem if I did this?
It's not level. It has to be
No,
higher.
let's say it's all level, it's all right.
There's still medication in the line.
Huh?
There's still medication in the line.
So
Then you're
what?
gonna unhook it, hook up something else.
So what's the problem with this?
Are you able to continue fluids or switch medication?
Exactly. So that's why what you guys need to do is before you start to infuse it, you set up your regular, let's say a 1,000 ml bag or 500 ml bag, your saline, right? You set up your saline is going in, and then this medicine gets connected as a connection, right? Like almost like a piggyback to this port. Why is this important? Because the moment I close this off, I already have my saline ready to go. I open this up, I infuse, so I can bring up the blood pressure. You get someone with this, you infuse this BP 60 over 40, perhaps you didn't put your monitor every 2 minutes, right? And you have saline ready, you're going to go in cardiac arrest. So you went from a stable, and the way you're going to document it, you're going to say, oh, patient had a stable V-Tach, now they're in arrest. Makes sense, right? The drug still is going, right? As you work in the arrest, the IV fluid is still going, right?
It happens.
I know. That's why I'm telling you this.
It happens.
All right. So this is, guys, if you haven't bought this, you can get this book on AHA site. It's in a digital form. My advice to you, get it, right? It has all the indications, contraindications for this medication. So amiodarone, right? We talked about indications. We talked about doses. Some of the precautions that I want to talk about, right? So rapid infusion leads to profound hypotension, which you want to monitor, right? And stop the infusion. If you have combination with other medication, it's going to prolong your PT interval. So be mindful about that. Don't give this medicine before torsades, right? So good idea to download this booklet and look at your indications, contraindications. Lidocaine, right? We talked about indications for your wide complex tachyarrhythmias. It's also used in cardiac arrest setting, right? So all this stuff is given here. there's one thing, right, in lidocaine, you may have, signs of toxicity developing. What are toxicity of lidocaine? Let's say I'm infusing it over 2 minutes. What is the sign of toxicity for lidocaine?
I'm gonna give it a guess. Is it irritation?
No,
No?
no.
Okay. I try.
All right, it's good. Hypotension, what else? Shock, right? So here, right, they show you the signs and symptoms of lidocaine toxicity. So cardiovascular effects will be what? They will show as tachycardia and hypertension. With increasing toxicity, you may have bradycardia and hypertension occurring, right? You may have other arrhythmias, breakout arrhythmias. The other side effects, right, usually they're CNS in nature, right, central nervous system. So 47 of these patients, right, that got IV lidocaine, what they have is drowsiness, paresthesia, right, this like pins and needles, lightheadedness, hearing loss, visual disturbances, dysarthria, euphoria, right? So the moment the patient says, like, I feel pins and needles, they feel drowsy, they feel lightheaded, or they say any type of visual disturbances, right? Perhaps you're at the point where you're causing, right, toxicity. And cardio effects will be breakout other arrhythmias, bradyarrhythmias, hypotension, right? So remember, ingrain this in your mind. Any antiarrhythmic was going to do what? Hypotension. Very good. Any questions? That this will be enough for today for you guys. Any questions about anything? Good? Right? Now you guys know your drugs now, right?
Kind of.
There you go.